丹分校神经病学及神经重症科的主任，他也是美国的前的重症学会的主席在重症领域以及在早期的昏迷救治中间，在国际上都是享有盛誉的。那么他也曾经多次来到中国进行这个经验的交流那么他今天呢，也主要就早期昏迷的一些情况呢，和我们一起来做一个这个分享那么我们有请Claude Hemphill。
Hi, my name is Claude Hemphill, and I am a neurologist and neurointensivist at the University of California, San Francisco, and San Francisco General Hospital. And I'm very honored to be able to be part of this conference and speak with you today about curing coma in the ICU and tell you a little bit about our experience from the TRACK-TBI, Traumatic Brain Injury Research Consortium, and the newly developed Curing Coma campaign from the Neurocritical Care Society. So the question is, why is a neurointensive care doctor speaking in a consciousness conference? Well, I think it makes a lot of sense because our patients experience a continuum of care from acute to post-acute across these recovery locations and different medical providers. But I find too often that many of us are stuck in our specific areas and don't understand that continuum of care. I particularly see that with intensive care unit doctors who really don't understand a lot of times what happens in the recovery phase of patients. Decisions made early in the care of patients influence whether they're going to survive and the resources and interventions that they receive in that post-acute stage. So this is really a time for acute and post-acute scientists and medical providers to improve our collaboration in order to improve our patient outcomes. I'd like to start with a case that sort of illustrates this a little bit. It's a patient that I took care of just a few weeks ago. Coma in the intensive care unit. This 56-year-old man fell off a bicycle and was brought to the hospital in a coma. His Glasgow Coma Scale score was 6. And he had a traumatic brain injury, a TBI. This is his CAT scan, which shows a large left soft tissue swelling where he hit his head, but only moderate injury on the scan itself. So what does his family ask? They probably aren't asking specific things like, should he get mannitol? What are you going to use for your ventilator mode? They ask, will he survive? Will he wake up? And what will his cognitive function be? And what can we do to improve his chances for these two things? And I think when we take a step back and think about neurocritical care, really the diagnosis, prognosis, and treatment of coma and disorders of consciousness is our central focus. That ultimately is the most important thing that matters to our patients. I was reflecting back on my learning about traumatic brain injury, TBI, when I was in training as a fellow learning about neurocritical care. And I remember that one of my mentors was a very senior neurosurgeon who was a recognized expert in traumatic brain injury. And he had a very strong commitment to the importance of early prognostication because he felt like it was really important to avoid the perception or concern of hopelessness and to prioritize resources. And it was remarkable how accurate he was in predicting whether his patients lived or died. He even developed a mathematical model called Predicting Survival from Head Trauma 24 hours after injury and published it. Now, this is 25 or 30 years ago, but he found that age was a near perfect predictor in his model, and he used this model to decide within one day which patients should receive aggressive care or which patients should, in fact, be allowed to pass away or transition out of the intensive care unit to other care pathways without aggressive care. And I went back and looked at my mentor's research study and looked at the outcome of patients. And it was pretty interesting because 60%, 59% of his patients died within 6 months. And that seems very high, especially given that other concurrent series such as the TCDB, Traumatic Coma Databank, the European Brain Injury Consortium, and the Australia-New Zealand group had a mortality rate that was about half of that. And that is when I realized that my mentor, I realized why he was so good at prognostication. There's a concept called the self-fulfilling prophecy. And this is not a medical concept, it's a social science concept. But the definition is, in the beginning, it's a false definition of the situation, evoking a new behavior which makes the original false conception come true. And the prophet, the person who uses this, will cite the actual course of events as proof that he was right from the very beginning. So how would this play out in the case of my mentor? Well, he would see a patient who looked very sick at the very beginning and look at them and say, I don't think they're going to survive. So therefore, we're not going to be aggressive in care. The patient would pass away a few days later. He would come back into the intensive care unit and say, what happened to that patient? He'd say, well, the patient passed away. And he'd say, well, I knew that was going to happen. These patients don't do very well. Let's hang on to that concept because it's a really important concept in how we help our patients. The other challenge we have in traumatic brain injury is we've done a lot of basic science research in the molecular mechanisms of traumatic brain injury. And there are so many different potential targets: free radicals, calcium influx, inflammation, excitotoxicity. And there have been a number of different clinical trials, and unfortunately, over 23 phase 3 clinical trials, all negative or neutral, based on pharmacology or hypothermia. So we don't have a targeted treatment in traumatic brain injury. So this has really led to the need to rethink acute traumatic brain injury, how patients are classified, how clinical trials should be designed to test new interventions, what systems of care are needed, and to think about TBI across the spectrum of injury, not just severe injury, but mild injury. So there have been two large international efforts in the last few years to address these issues. One is called Track TBI, which is in the United States, which I'm going to tell you a little bit about. And one is Center TBI, coordinated out of Europe. And these are now coming together for larger international efforts. The Track TBI is headquartered at San Francisco General Hospital and the University of California, San Francisco. On the far right, there's a picture of Jeffrey Manley. He is a neurosurgeon who is my colleague and friend and leads the Track TBI effort. And it stands for Transforming Research and Clinical Knowledge in Traumatic Brain Injury. And the idea is to shift from just classifying patients using a single measure such as the Glasgow Coma Scale to really trying to take a more precision medicine approach that integrates symptoms, clinical data, but also imaging and down to molecular medicine. So the Track TBI study initially sought to enroll 3,000 patients across the spectrum from concussion to coma. The idea would be 1,000 patients with mild enough injury so that they would be discharged from the emergency department, 1,000 who would be admitted to the hospital but not require the ICU, and 1,000 who were in the ICU, assuming that that was a very severely affected patients, with the goals of improving this classification, outcome assessment, and also creating an information commons to promote collaboration and acceleration of TBI research, with an emphasis on the health and economic impact of milder traumatic brain injury, which has been understudied. So these are 19 sites across the United States, many of whom are acute care, some of whom are rehabilitation sites. And we enrolled the 3,000 subject a little over 2 years ago. And there's been a lot of work in continuing to follow these patients for clinical, imaging, and proteomic outcomes. But what's been interesting is when we've looked at traumatic brain injury in the Track TBI study, and it's really all comers, just who comes through the hospital door, we realized that most of these patients are not severely affected. Most of them are not in coma. The majority of them have what we would classify as a concussion. So this is a big deal in terms of thinking about how we impact on TBI care and improve TBI care for patients across the population. Now, this is a little bit of unpublished data that shows the enrollment as of earlier this year. And what it shows is at the bottom, it shows the patients who were discharged from the emergency department or hospital admission or hospital admit with ICU. Now notice we've got more than 1,000 in the ICU. And the reason is that we were surprised, but a large portion of the patients admitted to the ICU turned out to have less severe injury. They were admitted to the ICU to watch them in case they deteriorated, as opposed to just manage severe TBI and intracranial pressure. And so when we looked at our initial ICU cohort, we found that the average age is about 43 years, which is older than the population used to be of TBI. Back 30 years ago, many of these studies found that ICU patients tended to just be on average in the 20s. So our population is aging, and we're seeing an older population. I believe the Center TBI study has found even an older, higher average age. As I mentioned, many patients admitted to the intensive care unit are what is now being called complicated mild TBI patients. These are patients who may be awake, but have abnormal CT scans and are concerned for high risk of deterioration. So only 29% of the patients in the ICU had severe enough traumatic brain injury to undergo intracranial pressure monitoring. And you can see that the patients who did not have ICP monitoring had a median Glasgow Coma Scale score of 15, which is the highest score. And the patients who had ICP monitoring had a median Glasgow Coma Scale score of 3, which is the lowest. So they were much more severely affected. And the 6-month outcome reflected that when we looked at the Glasgow Outcome Scale extended. It's an 8-point scale, with 8 being the best and 1 being the worst, indicating death. The median was 7 for those patients that weren't severe enough to need ICP monitoring, even if they were admitted to an ICU. But the patients that got ICP monitoring had a median outcome of 3 and had a mortality rate that's about 5 times higher. So these are just some initial findings. And a lot of the work that's proceeding is trying to look at biomarkers, imaging, and longer term outcome to improve the way we can classify and design clinical trials. I want to give you a couple of highlights from the TRACK TBI study. This is actually in mild patients, but the U.S. Food and Drug Administration 2 years ago authorized the first blood test for concussion, and this came out of TRACK TBI using a GFAP and UCHL1. So within 12 hours, we can look at this. Precision imaging is key for TBI, and we showed that case at the beginning of the talk where there wasn't a whole lot of abnormalities seen obviously on that CAT scan, but the patient was in a coma. We call that invisible injury because we really have an uncertain outcome at that time. So if we can look, as we are doing in consciousness research with MR tractography and the real-time Connectome, this would hopefully provide information for patients even in the acute setting. Challenge though, these are complicated studies, take a long time to run, not to mention the challenge of getting them in critically ill patients and resource availability. But some of the work in TRACK TBI has been collaborating with data scientists to try to accelerate the way Connectome is analyzed, moving run times from 19 hours to 6 hours, 8 hours to 20 minutes with the Connectome, using something called FreeSurfer and MRI segmentation. And now the TRACK TBI long study, which is really trying to look at long-term outcome and issues of psychological, neurodegenerative diseases in these patients as well. I mentioned Center TBI, and this is the website for Center TBI, an analogous group that really is a fantastic group to collaborate with, and they're doing many similar approaches on patients across European centers, and INTBER as the International TBI Research Initiative, not just in the US and Europe, but really involving China and Australia and Canada. So there's a lot of interest in TBI collaboration. But I want to take us back to thinking about those severely injured patients and coma, and ask the question, how do we prognosticate currently? What is our current approach? Well, we prognosticate based on phenotype, meaning the neurologic examination that the patient has in front of us. What do they look like? What is their motor exam? What is their Glasgow Coma score? demographics, which is their age, maybe other medical conditions they have, imaging, such as anatomy, like how big is the lesion, where is the hematoma, and we develop mathematical models based on this data, not just for traumatic brain injury, but across many different diseases. And here we show a couple of figures of commonly used models. On the left, there is the impact model for traumatic brain injury. On the right, there is the ICH score, which is one model for non-traumatic intracerebral hemorrhage. And notice what these all have in there. They have these same prognostic criteria. And this brings us back to the self-fulfilling prophecy, because we still have the self-fulfilling prophecy, even though we have these models. And a reminder that the self-fulfilling prophecy in neurocritical care occurs when aggressive care is not provided because of a presumed poor prognosis and a patient who would otherwise recover does not. Sometimes the patients die. Sometimes the patients are just not provided as aggressive care, rehabilitation, and recovery resources, and they don't recover to their full potential. But this turns out to be a problem in all neurocritical care conditions. It's not just traumatic brain injury. It occurs in hypoxic ischemic brain injury after cardiac arrest, ischemic and hemorrhagic stroke, subarachnoid hemorrhage. And the question, why aren't we better than this? Well, it's probably because we're currently assessing what the patient looks like rather than assessing what the true underlying mechanism of coma or impaired consciousness is and the capacity of the brain to recover. We haven't had the ability to do that. But 10 years ago, it was really a breakthrough landmark study from Dr. Laris's group, where they looked at patients who were in vegetative or minimally conscious states and identified that 9% of them had responsiveness on functional MRI. These patients were in there, even though we couldn't tell they were in there based on our neurologic exam. This is such a critical effort. But these patients were in the post-acute phase. So a study came out last year from Jan Clausen at Columbia, looked at patients in the intensive care unit, and had similar analogous findings using advanced EEG with machine learning, what we now call cognitive motor dissociation. We don't see responsiveness on our clinical exam, on our motor exam of the patients, but we see it based on our special diagnostic test, in this case EEG, in the prior one functional MRI. And patients with cognitive motor dissociation were much more likely to recover. Novel clinical neurologic assessment can also provide clues to coma emergence. Just something as straightforward as using a mirror to assess visual fixation, or the idea that the initiation of swallowing can indicate prognosis of disorders of consciousness. So this is really powerful and really important because we have imaging, electrophysiology, and neurological examination information that we can start to look at for this cognitive motor dissociation and emergence from coma and impaired consciousness, starting perhaps in the ICU and going into the post-acute period. So when we think about curing coma in the ICU, ask, where are we now? Well, recovery of meaningful consciousness is usually the most important outcome for patients and families. And I think we probably come about as far as we can with the standard way we do things, with our neuro exam, demographics, and standard imaging. We're wrong an unacceptably high amount of the time, and this enables this self-fulfilling prophecy. Problem is, we don't use or even have treatments that are focused on the mechanism of coma and impaired consciousness and its recovery, and there is this disconnect between the science and the clinical care, between the acute ICU time and the subacute post-ICU and recovery environments. So this led us in the Neurocritical Care Society to want to tackle this by developing something we call the Curing Coma campaign. And as we said, this is addressing that most common question and compelling question across different diseases. And it's interesting that the journal Science identified the biological basis of consciousness as the second most important unanswered question in science. Number one is, what is the universe made of? That's a biggie, but consciousness is really so important. So the Curing Coma campaign, I want to tell you a little bit about it. It's a multidisciplinary international effort to address this grand challenge by advancing the fundamental science of acute care and recovery and creating the community to implement this now and in the future. And that second part is so important. It's been organized by the Neurocritical Care Society and kicked off just a little bit more than a year ago with an idea of a 10-year scientific roadmap. And we published the first paper, that's last year, from our Scientific Advisory Council to frame the initial scientific challenges and consider perhaps 3 scientific pillars that may help us move forward with this: endotyping, biomarkers, and proof of concept clinical trials. And one of the really key aspects of this is emphasizing that continuum from acute care to recovery. I, as an ICU provider and clinical scientist, need to be working more and more substantially with my post-acute and rehabilitation recovery specialists and vice versa. Our patients, they are our shared patients. We've got to work together. So I want to take you through a couple of these. I want to take you through these 3 scientific pillars as I tell you a little bit more about the Curing Coma campaign. Endotyping. Notice we didn't say phenotyping, because we recognize that different disease entities and structural or metabolic mechanisms can result in similar clinical phenotypes. That's the problem we have with cognitive motor dissociation. Patients may look clinically the same. They've all got a Glasgow Coma Scale score of 6, for example, or impaired corneal reflexes, but they have different underlying mechanisms of coma and potential for recovery. So it may be that it's not the disease, traumatic brain injury or stroke, but it's the nature of the coma and disorder of consciousness that's more important about their ability to recover. So we thought about perhaps a new classification that focuses on a disorder of consciousness without commensurate structural damage, with structural damage that's amenable to intervention, structural damage that's not currently amenable to intervention, but with future research it can be, and disorder of consciousness mimics like locked-in syndrome, where someone actually has consciousness, but we have to assess that in more deep fashion. So many of you are probably familiar with this mesocircuit model of consciousness and brain injuries. I'll tell you, my colleagues working in the intensive care unit are not. They don't think about this. But the idea is that there is a network. We're used to thinking about things in terms of lesions. There is a lesion in the left frontal lobe. But I think we need to shift to think about consciousness and coma in the ICU and beyond as a network. And how is this network disrupted? How can we detect that? And how can we potentially intervene on that? And that's where biomarkers come in. Improved tools needed to assess coma and disorders of consciousness. And we showed some examples, such as the advanced functional MRI or tractography, quantitative EEG, novel neurologic assessments. One of the challenges is taking these and making them user-friendly enough so that we can use them in different resource environments and in our acute patients. But we're starting to do that. And there's a study from critical care medicine from France earlier where they used functional MRI during the intensive care unit stay in patients after cardiac arrest to assess this network. Diffusion tensor imaging of the reticular activating system in the brainstem in intracerebral hemorrhage was found to correlate with the ability to improve with regard to level of consciousness and emerge from coma in a study in 2019 from Zhang in stroke. And so here's how this might work. Here's an example called personalized connectome mapping. On the left, there's a healthy control, and on the right, there's a patient who has acute severe TBI. They obviously look different. And this patient on the right was minimally conscious on day 7. But notice there are retained connections in this patient. And in fact, he was functionally independent at 6 months. So identifying this and intervening may be a very powerful approach. That leads us to proof of concept clinical trials. See, the goal would be to improve recovery of consciousness through new treatments, hopefully that we initiate in the acute setting and continue or initiate in the post-acute setting. We've got the Amantadine study from 2012 and Joe Giacino's group, and this is really powerful because it showed accelerated recovery when begun 4 weeks post-traumatic brain injury in unresponsive wakeful minimally conscious patients. This is not the end. This is the beginning. It's proof of principle. And there's a National Institutes of Health sponsored set of studies from Brian Edlow at Massachusetts General Hospital called STIMPACT. And the idea is he would take stimulant therapy targeted to individualized connectivity maps to promote reactivation of consciousness. The idea of identifying these patients whose connectome is amenable to neuromodulation with IV methylphenidate. So this is a lot in thinking about how we're going to cure coma in the ICU and beyond. So we're just getting started with the Curing Coma campaign. We were fortunate enough to co-sponsor a Curing Coma Symposium last September with the U.S. National Institutes of Health, and we had 384 attendees from 37 countries. We have a follow-up symposium on May the 3rd that may hopefully be in person, but will definitely have a virtual component. We have the Come Together Coma Care Research Survey Study to look at coma care patterns across the world, and that's being completed now. We're developing common data elements so that we can speak the same language in research studies for coma, just as we do in traumatic brain injury and stroke and other diseases. And finally, we're really excited about World Coma Day. This is a new thing. It's going to be on March 22nd, 2021. I would invite all of you to be part of World Coma Day. We want this to be an opportunity to present science, such as the Come Together Research Survey Study results, to provide education, to provide an opportunity for input and education from our families. So please become part of the Curing Coma campaign. You can sign up on the website here at www.curingcoma.org. So let's conclude. When we talk about curing coma in the ICU, what can we do today? Well, the first thing we can do is acknowledge uncertainty in prognostication and be humble, and provide our aggressive care and give our patients a chance to recover. We have to recognize and avoid the self-fulfilling prophecy. On the other hand, we still have to work with families to make decisions now in severely injured patients. We would recommend that we incorporate guidelines into our patient care model. Here is an example of the European Academy of Neurology guideline on the diagnosis of coma and other disorders of consciousness that was published earlier this year. And this is really a landmark guideline that I think can help us move forward. And where do we need to go? Well, we need to develop user-friendly biomarkers that can be used to augment our current exam and imaging to identify patients that have the capacity to recover. We need to create and test new treatments, medical, surgical, rehabilitation, that can leverage the capacity to recover. We need to further develop an organized ethics framework for coma care and treatment. And I think probably most importantly, we need to create the community of providers, scientists, and patient advocates to do this together. I really appreciate the opportunity to be part of the conference, and I'm so excited to have been able to share with you a little bit about Track TBI and about the Curing Coma campaign. Enjoy the rest of your conference, and I look forward to working together in the future. Thank you.